Hi, I'm Dr. Meredith Brower. I am one of the fertility doctors here at Reproductive Partners. And this month, if you're not aware, is PCOS, or Polycystic Ovary Syndrome Awareness Month. PCOS is common. It is the most common endocrine problem affecting about 10 to 13% of reproductive age women. So it's something we see a lot. PCOS has been defined multiple ways over time. It can be a little bit confusing. One, there have been several different ways to define it. Number two, it's heterogeneous. Not every woman with PCOS will look the same. And the third is that the acronym itself is a bit of a misnomer. We call this Polycystic Ovary Syndrome. Many people who have been given this definition naturally assume that they have cysts in the ovaries, but the reality is that there's extra eggs and follicles in the ovary, but they're not really cysts. So how do we define PCOS? PCOS is defined having 2 out of 3 criteria. First one is some evidence of excess androgens. Androgens are what we classically think of as male hormones. Testosterone, DHEAS is a weaker androgen, but the truth is that everybody makes some testosterone, everybody makes some DHEAS, but what happens in PCOS is that there's an excess production of these hormones, and it can be seen either in the blood. You check someone's blood levels for these hormones and you'll see them to be elevated, or you can see it clinically, or both sometimes. And the clinical symptoms of excess androgens would be excess hair growth, facial hair growth from the breast, abdomen, the belly, the back, or acne, or male pattern hair loss. So those are the clinical symptoms of excess androgens. The second criteria is ovulatory dysfunction. Ovulatory dysfunction means that an individual is not ovulating. That will typically present with irregular periods. We define regular periods or cycles as somewhere between every 21 to 35 days. Third one is the way that the ovaries appear on a transvaginal ultrasound. In women with PCOS, there are lots and lots and lots of follicles. Any individual with more than 20 follicles on a single ovary would meet that definition of what we call polycystic ovary morphology. So to meet the criteria for PCOS, you need to have only 2 of those 3 criteria. Some people will have all 3. Some people will have a really mild version of it. Sometimes they even have regular cycles or no evidence of excess androgens. When we think about the management of PCOS, 3 things that I like to think about. One is, how do we optimize? Number 2, what are our treatment goals? Improvement of the symptoms associated with PCOS, or fertility. Women with PCOS are at increased risk for other disorders: obesity, metabolic disease, cardiovascular disease, sleep apnea, diabetes and prediabetes, and infertility. Right? So we need to keep those things in mind and test for those. Have a blood pressure checked. They should have a lipid panel or cholesterol panel done. We want to do some blood sugar testing. See if an individual has already developed some of those diseases. So always step 1 is optimization. Our first line of treatment is often birth control pills. The birth control pills can decrease the production of the testosterone and other androgens from the ovary. We have some other tools we use over here. Metformin is one that we use for the metabolic piece. Medications like spironolactone that we can use as well to help improve symptoms. Now, if individuals trying to get pregnant, the management's very different. So the support of fertility care in women with PCOS is often trying to promote ovulation, and that's called ovulation induction. First line treatment for that is a medication called letrozole, which is an oral medication that can promote the ovulation in someone who's not ovulating due to their PCOS. Thank you for listening today. I am Dr. Meredith Brower here in our Beverly Hills location. We'd love to see you here for a consult anytime with either myself or one of my partners.